So the next topic is about the heart sounds on which a lot of questions have come. For today we will review the quickly what are all the questions asked, so that prepare and come, doctor, always, because already the summary of all topics is there with you. If you come prepared, you can only search what else is being spoken here. That is more easier and enjoyable way of attending a class, is my plea to you. So now let us quickly talk about the questions on heart sounds. The first heart sound is soft. Generally it is loud, but if it is soft, what does it indicate? It indicates a VSD or a MR or a calcified valve will make the heart sound, first heart sound, closure of AV valve to become soft. But if it is a short PR interval or a mitral stenosis, it becomes loud. So we will later on examine what are all the underlying causes. So a long PR interval, MR, immobile mitral leaflet, left bundle branch block will make the S1 to become soft. Whereas a short PR, MS, or a shortened diastole due to tachycardia, the easiest way to examine a loud S1 is either go to mitral stenosis patient, you will have a lot of them, or tachycardia also. You run and then auscultate your own heart sound. S1 will be loud. Then wide split S2. S2 is what? A2 first, P2 later. Wide means either early A2 should be there or a delayed P2 should be there. So when will it happen? Typically a fixed and a wide splitting of S2 is the auscultatory hallmark of ASD. Now why in ASD there is a widened split? Because ASD is left atrium to right atrium. Right? So from right atrium to right ventricle opens into pulmonary valve. So pulmonary valve become delayed. So that leads to widening. What do you mean by fixed split? Normally with inspiration what happens, there is an increased venous return into the right side of the heart, and that will make the right ventricle receive more amount of blood. Right atrium receive more amount of blood from the systemic veins. Inspiration will cause increased venous return to the right atrium, into the right ventricle, into pulmonary valve. So the pulmonary valve become further delayed. So generally during inspiration there is a increased venous return, increased flow across pulmonary valve, and increased widening of S2. But what happens in ASD? In ASD, the left atrial blood is flowing into the right atrium. So the right atrium has some pressure built inside it. That intra-atrial pressure will say that at the time of inspiration, when more venous return want to come, it will say that I have already a lot of unnecessary homework given by this left atrial fellow. With the ASD, he is pumping me unnecessary extra work to me. Why at the time of inspiration you are also giving me some extra blood? I am not ready. But the systemic veins will say, please take our blood, because there is a negative intrathoracic pressure, we are expected to push extra blood into you. Left atrium says, generally I listen your word, but I have a septal defect here. So already I have some pressure inside you, check if you can push the blood into me. And systemic veins can't push blood into a already high pressures which are there in the atrium. So that is the reason there is a widening of the split, because of left atrium into right atrial blood is causing more amount of blood into right atrium to right ventricle into pulmonary artery. But there is no further widening at the time of inspiration, because that high pressure inside the right atrium will not permit any further increase of the venous return into the right atrium at the time of inspiration, is what you need to basically remember. Now let us talk about the various heart sounds which occur before S2, which occur after S2, etc., etc. We must be very sure. Fundamentally the clicks, aortic and pulmonary valve clicks, they occur after S1. S1 is AV valve closure. That is the time some phenomena is happening between ventricle and the aorta, or the ventricle and the pulmonary artery. So click, these clicks are, the valvular clicks are happening at aortic and pulmonary valve level, they occur after S1. Then shortly before S1, what do you have? S1, S2, S3, S4, S1. So fourth heart sound, and it is also called atrial gallop basically. Then shortly after S2 is because of the closure of aortic and pulmonary valve, and that is the time where mitral valve will open. So opening snap will occur after the S2. And similarly, any pericardial knock or tumor plop or the S3, they all basically happen shortly after the S2. Okay? Now, how do you explain that S3 happens after S2? Basically, why will S3 happen? It is the left ventricle which is failing. A failed left ventricle is responsible for S3. So, when will the failure of the left ventricle will be known? When the left ventricle contracts. And when will it contract? After the atrium is full and the AV valves, aortic and pulmonary valve has closed, then the next process is, it should basically show its activity. So S3, tumor plop, pericardial knock, opening snap, they are all shortly after the S2. And a mid-systolic click is what you listen between the S1 and the S3 is what I like to underscore, and I am giving you a quick summary of which is of high pitch, low pitch, when do you listen, etc., etc. We will discuss more in the theory. Now with regard to the third heart sound is a failing left ventricle. Do you find it in mitral stenosis? What is the problem in mitral stenosis? Basically, from left atrium blood is not going to left ventricle. Left ventricle has no homework at all. So where is it challenged? If it is not challenged, you don't know whether it will fail or win. So it is not taking the subject tests and Sunday tests. So in MS, it is not put to a test. So S3 will never be heard. If S3 is heard, it cannot be a pure MS. What is one more rule? If there is a left ventricular dilatation, it is not pure MS. Why? Do you expect the left ventricular apex to become dilated? No. Why? Because if it is a pure MS, the left atrial blood is not going to LV at all. So there is no chance of LV getting dilated or overworking. So a left ventricular enlargement on X-ray or the apex enlarged out on clinical examination or finding an S3, they are all against a pure MS. If MS is associated with the MR or MS is associated with the AS in rheumatic fever, then S3 will appear, left ventricle will dilate, X-ray will show cardiomegaly, and all these features will be found, is what you need to basically remember. Then S3 can be a normal finding in certain subsets of population. Sometimes in those who are aged less than 40, but generally it indicates a impaired ventricular function, AV regurgitation, and etc., etc. So where do you have physiological S3, doctor? Athletes, healthy young adults, pregnancy, fever, etc., etc., you may find it. Now where do you have a single heart sound? TOF. In TOF, what are the four lesions? VSD, PS, right ventricular hypertrophy, and the overarching of the aorta. So it is the pulmonic stenosis, atresia, which leads to the P2 to be absent, and that leads to development of a single S2, which is because of A2 rather than P2 in case of the TOF, is what you need to basically remember. So any pulmonary atresia or tricuspid atresia or Eisenminger's VSD or severe TOF or age greater than 50 can some of the few conditions leading to single S2. Loud S1, where do you have? Loud S1 is basically seen in case of a short PR interval or a mitral stenosis, as already we have discussed it. Then we have a wide split second heart sound. As we already discussed, ASD is one of the important causes. Now left ventricular S3, where do you have it? MS purely doesn't lead. If there is an associated MR Then why associated MR will lead to S3? MR means what is happening? When the left ventricle is contracting, it is expected to contract into aorta, but MR will cause regurgitation into LA, left atrium, and once more all that additional blood will come and fall in the next diastole back into the ventricle. So ventricle every time is doing some pumping, but something is going back and coming back in the next contraction. So finally left ventricle is doing work, but it is a useless work. One step ahead, three steps behind. So then finally left ventricle will fail, and that reflects in the form of S3. Now reverse splitting of S2, when will it happen? If aortic A2 got too delayed or P2 got too early, then that lead to reverse splitting. A2 comes first, P2 comes next. So if the A2 got too delayed or P2 comes too early, reverse splitting. When will it become widened splitting? If the A2 is early and P2 is delayed, widened splitting. Okay? Now, so out of all this, it is the left bundle branch block or LV pacing or systemic hypertension, any of them, what will they do? They will make the left ventricle to contract slowly, A2 become delayed, and it will cross the P2 and lead to reverse splitting is what you need to basically remember. Now out of all this, what is the diastolic sound during the cardiac auscultation? It is the gallops which are fundamentally the diastolic sounds is what we need to fundamentally understand. Then ASD leads to wide splitting. Now where will reversal splitting of first heart sound will occur? Normally in the first heart sound, mitral valve closes first, tricuspid later. Anything that delays, it is reverse, right? Delays mitral valve or early tricuspid will cause reversal splitting of first heart sound. When will that happen? It typically happen with the left bundle branch block or left atrial myxoma or a severe mitral stenosis. Any of them will make the mitral valve closure become a delayed event, and that will cause a reversal splitting to happen. Okay? Now, the loud pulmonic component of the second heart sound, where do you have? If there is a pulmonary hypertension, what are the important features? Where is the pulmonic area? It is the left second intercostal space is pulmonic, right second intercostal is aortic. And what is neo-aortic area? Third and fourth left intercostal space are neo-aortic area. Where do you listen for the aortic regurgitation murmur? Not in aortic area. That is you don't listen it in second right intercostal. Rather you hear it in third and fourth left intercostal, which is the neo-aortic area where early diastolic murmur will be heard. If there is a pulmonary hypertension, what is the important features? If you need not even place stethoscope also. There is a pulmonary knock is a classical feature. Parasternal heave will be there. A palpable P2 will be a classical feature of the pulmonary hypertension is what you need to fundamentally understand. So a loud P2, splitting of the S2, which is diminished, normal or accentuated depending on the peripheral vascular resistance and RV decompression, and is a very classical feature of the pulmonary hypertension. Here is a wide split second heart sound. Where do you typically come across? Wide means what, doctor? Wide split means early A2 or delayed P2. So why in MR early A2 will occur? Because when left ventricle is contracting, it is contracting and pushing blood into aorta. Suppose if regurgitation is happening, what will happen? Left ventricle is contracting, quickly blood is going out, blood is going down. Finally it empties fast. So naturally aortic valve will close fast, and that lead to early A2, which will lead to widening of the S2 is what you need to basically remember. Now the ejection click, where do you listen? Always the presence of ejection click is an indicator of the pathology, valvular pathology of aortic valve or pulmonic valve is what you need to basically remember. Now where do you see S4? S4 is basically called as a non-compliant left ventricle is called S4. A failing left ventricle is S3. A non-compliant left ventricle is, what do you mean by non-compliant? The left atrium pushes the blood into left ventricle. But if the left ventricle is not distending well, what will left atrium do? Please distend, let me push the blood into you, and that creates the rumbling of the blood inside the left ventricle, and that reflects as S4. So S4 is suggestive always of a non-compliant left ventricle. But if the left ventricle fails, it is S3. And do you perceive S3, S4 better with a stethoscope or with fingers? It's more a palpatory finding, S3 and S4, than that of a auscultatory finding is what you need to basically remember. S1 and S2 are more of auscultatory findings than the palpatory findings is what I like to underscore. So S4 is a low pitched pre-systolic sound produced in the ventricle at the time of a rapid filling from the atrium into the ventricle. When it is happening, you listen the S4. So any aortic stenosis, hypertrophic cardiomyopathy, ischemic heart disease, mitral regurgitation, anything that makes the stiff left ventricle which is non-compliant, that leads to the development of the S4 is what I like to underscore to all of you. Now let us talk about the third heart sound which we already discussed. It is never seen in the case of the pure mitral stenosis. So with this we end the theory, the questions. You have now understood that delayed splitting of S2, reverse splitting of S2, delayed splitting of S1 and reverse splitting of S1. S3, S4 clicks. If you know that, one question you can confidently definitely answer in cardiology.